Hello and welcome. I'm Fernando, a GP in the UK. Today we're looking at the NICE updates published in August 2024, focusing on what is relevant in primary care only. We're going to cover just two areas, the treatment of osteoporosis and the management of diabetic retinopathy, so it is a brief episode. Let's jump into it. The first area is a technology appraisal on Abaloparatide for treating osteoporosis after the menopause. And you may be thinking, Abaloparatide, is this really something that we need to know about in primary care? And the answer is yes, and let's see why. And we will start by saying that treatment of osteoporosis can be broadly divided into two types. Anti-resorptive treatment, which slow the rate of bone breakdown, such as our usual biphosphonates, and anabolic or bone-forming treatments. Treatment with anabolic skeletal agents result in rapid and greater fracture risk reductions than biphosphonates. So, if you used to prescribing bisphosphonates for the majority of our patients, who should be getting anabolic agents instead? And the guidelines stipulate that people with a very high fracture risk should be referred for the consideration of these agents. According to the National Osteoporosis Guideline Group, very high risk is defined as a FRAX-based fracture probability that exceeds the intervention threshold by 60%. So, looking at this diagram based on FRAX, we can see how patients can fall into the different risk categories depending on their scores. Apart from the patients already in the very high risk of fractures, we should also consider additional clinical risk factors for patients in the high risk category. For example, frequent falls or a very low spine bone density, in case that these risk factors may move them from a high risk to a very high risk of fracture. So, in summary, we need to be aware that these anabolic drugs exist and that they are recommended for people with a very high risk of fractures, so that when we see such patients, we refer them appropriately to get these drugs. Existing anabolic treatments are romosozumab and teriparatide, and following this technology appraisal, NICE recommends abaloparatide too. These anabolic agents can only be taken for a limited time between 12 and 24 months depending on the drug, and afterwards patients will continue to receive an anti-resorptive treatment such as an oral biphosphonate. Although abaloparatide is licensed for the treatment of osteoporosis in postmenopausal women, we must also include trans men and non-binary people registered female at birth. The next area is a brand new NICE guideline on diabetic retinopathy, its management and monitoring. It is mostly aimed at the diabetic retinal screening service and ophthalmologists, but it also covers some areas of diabetic care that affects us in primary care. Let's have a look at it. Firstly, we should always discuss with patients that good long-term diabetic control can have long-term benefits for their vision. Then, the second recommendation refers to the effects on retinopathy of a rapid reduction in HbA1c. This is because there is some, although limited, evidence about the potential risk of worsening retinopathy from treatments that result in a rapid, substantial drop in HbA1c. Early worsening of diabetic retinopathy does not necessarily mean that the treatment is harmful in the long term, but instead it highlights the need for close monitoring. NICE therefore recommended that an ophthalmologist should assess the patient before intensive glycemic treatment is started, and then closely monitors for changes afterwards. We know that both HbA1c and blood pressure levels can be used to predict the likelihood of retinopathy progression. So the third recommendation is that ophthalmologists should have access to the person's HbA1c and blood pressure records. Additionally, NICE has highlighted that the presence of renal disease can also influence retinopathy progression. The evidence for this is of low quality but is supported by clinical experience. Also, we know that managing blood pressure in hypertensive patients can reduce retinopathy progression, so achieving good blood pressure control is important. However, we must also be aware that reducing blood pressure with antihypertensives in people who do not have hypertension has no such positive effect. There is some evidence that fenofibrate is beneficial for people with type 2 diabetes in respect of retinopathy progression. However, there is no evidence on other outcomes such as visual acuity or quality of life. NICE therefore recommends that it should be ophthalmologists who initiate fenofibrate for this indication. There is no evidence for people with type 1 diabetes, so they're not included in the recommendation. NICE has recommended further research about statins preventing retinopathy progression because there is no strong evidence to this effect. The rest of the recommendations are entirely for secondary care and cover areas such as cataract surgery, as well as recommendations on the treatment and frequency of monitoring for both proliferative and non-proliferative diabetic retinopathy and diabetic macular edema. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, and it is only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching, and goodbye.